Hello, my lovely friends. I'm Dr. Arun Swami. Once again, welcomes to all of you on my channel. In this session or in this video, we'll discuss about the high yield MCQs from upcoming various examination like FMG or NEET PG from cardiovascular system. As we know that cardiovascular system is the very important system that's favorite for the examiner, so we should not skip. So let's start talking about what are the high yield areas for upcoming examination about this cardiovascular system. So the first question is a 26-year-old male presents with after massive blood loss due to trauma. BP is 70 to 40 mmHg, heart rate is 132 per minute, and cold calm skin, which reflex is most immediately responsible for the tachycardia. Option A is Bain-Bridge reflex, B is Bajor-Jeris reflex, arterial baroreceptor reflex, or the chemoreceptor reflex. Let's talk about how to approach such questions whenever they are going to be asked in the examination. So guys, the first thing, you should identify the key areas from the MCQ that how you should answer properly for this question. So the first thing is that BP is 70 by 40 means there is a hypotension and heart rate is high, that is 132 per minute. The right answer, first of all, the right answer of this question is the option number C, that is arterial baroreceptor reflex. Now, how to approach such questions? The question patient is telling about the acute massive blood loss due to the trauma, means the blood loss is there, means person is having low amount of the blood which leading to hypovolemic shock. In hypovolemic shock, we know the BP should be less, so BP is 70 by 40, which is severely low, and heart rate is high, means the person is in tachycardia. Now, also in the question, there is hint is given the cold and clammy skin, which increase the sympathetic activity. So whenever there is a cold extremities, our body response is there that our body increase the sympathetic activation. And if the sympathetic activation will be high, the heart rate will be increased. Guys, in this condition, when there is a hypovolemia, the venous return will also be less. Venous return will also be less. So what is going to be happen? If BP is less, there is a decreased stretch of the carotid sinus and the aortic arc of the baroreceptor. And few things about the baroreceptor as well. We know that this is the heart, and from the heart, that pipeline which is originating like this, we called as aorta, and upper extremities or the upper areas of the body is supplied by the carotid artery. So you can see over here, this is your aorta and this is your carotid artery. Guys, two sensor God is placed over here. One is over here and one is over here, and these combinedly we call that baroreceptor. These baroreceptor are pressure sensing sensors. So whenever there will be the high pressure, these baroreceptor will be fired, but if pressure will be low, these baroreceptor will be deactivated. Now guys, please pay attention. So if BP is less, there will be stretch is decrease in this carotid sinus and the aortic arc for the baroreceptor, which leading to afferent firing via cranial nerve 9 and the cranial nerve 10 will be decreased. Decreased vagal tone lead to increased sympathetic outflow, and this sympathetic outflow will lead to what? Tachycardia and the vasoconstriction. So what will be happening? That BP will be try to increase for the body and heart rate should also be increased. Now remember that most immediate reflex which is responsible for tachycardia in acute hypotension is arterial baroreceptor reflex. Guys, this is very, very important areas. So God is placed is actually the two receptors over here, one for the pressure, that is baroreceptor, and another one is over here. This is for the oxygen level or the chemical, and this two collectively we called as chemoreceptor. This we call as chemoreceptor. So this is how the two sensors is present, one in the aorta, one in the carotid artery. This is one for the pressure, one for the chemical conditions like the oxygen, CO2 level. So these are we collectively called as baroreceptor and the chemoreceptor, and as they are outside of the brain, we call them peripheral baroreceptor and the peripheral chemoreceptor. If any of these receptors present inside the brain, we can call them central baroreceptor or the central chemoreceptor. So guys, please pay attention. The different reflexes, that is number one is Bain bridge reflex. Very important part. What is the Bain bridge reflex? The Bain bridge reflex, the trigger part is, this is increase the venous return. This happens due to the increased venous return. Increased venous return will lead to the overstretching of the right atria because all blood draining into the right atria. It will causes the tachycardia, and this tachycardia we called as a Bain bridge reflex. This seen in fluid overload and rapid IV infusion. Another one is the Bajol-Jeris reflex. This triggered due to the ventricular stretch or the chemical stimulation. And this causes bradycardia, hypotension and the apnea. So guys, please pay attention. Very important part. Very favorite for the examiner. The Bain bridge reflex and the Bajol-Jeris reflex. In Bain bridge, there will be a tachycardia, but in Bajol-Jeris reflex, there will be the bradycardia. Please pay attention. And another one is this seen in the inferior wall MI and spinal anesthesia, that is for the Bajol-Jeris reflex, but chemoreceptor reflex. One more, the chemoreceptor reflex, just now we discussed. This triggered due to the decrease the oxygen level or increase the CO2, or if the pH is going towards the acidic side, means the decreased pH. It will cause increase the respiration and there will be the mild tachycardia, and it will going to be act when the partial pressure of oxygen is below 60 mmHg. So this is we called as chemoreceptor reflex. Very high yield area, very favorite for the examiner. In NEET PG, in FMGE, they used to ask from these reflexes. Please remember all of this part. Coming to the next question. All of the following occur in early hypovolemic shock except option A is increase systemic vascular resistance, decrease capillary hydrostatic pressure, decrease venous return, or decrease heart rate. Guys, as the question is saying, please you should be very much careful during the examination day. There could be asked the except, least likely, or there could be the most common, second most common, like this. So guys, you should be always be careful to avoid the silly mistakes during the examination, right? As the question is saying, all can be seen except, means something is not going to be seen in this condition. So guys, we know in hypovolemic shock, there is not decrease the heart rate, there is always increase the heart rate. So this is exception. This is the exception. So right answer of this question is D. Decrease heart rate not seen. Always in hypovolemic shock, there will be increase in the heart rate. Please pay attention. If the hypovolemic shock is going to be there, guys, volume is less, so systemic vascular resistance will be increased. Why? Because there will be the sympathetic activation, there will be a vasoconstriction. Decrease capillary hydrostatic pressure, volume is less, so there will be hydrostatic pressure will be decreased in hypovolemic condition. And also due to the hypovolemia, venous return is also less. But as a compensation, when the sympathetic outflow is increased, ideally heart rate should be increased, not decrease, right? Now, so please pay attention. In early hypovolemic shock, blood volume decrease, BP decrease. What is going to be happening? The baroreceptor reflex activate the sympathetic system, very important, and this lead to tachycardia, means heart rate is increased. Also remember, that's different type of shock, and you have to remember, because all the time one question can be asked from the shock areas. So guys, number one is hypovolemic shock. Hypovolemic shock, it causes the hemorrhage. It causes in the hemorrhage, dehydration, and in the burns condition. The primary problem is there is a decrease intravascular volume, so the preload is also decreased. What is the key feature in the hypovolemic shock which you have to remember? Number one, cardiac output will be decreased. Cardiac output will be decrease. Increase systemic vascular resistance, so the cold and clammy skin will be there. Increase heart rate due to the baroreceptor reflex, and decrease the central veins pressure and decrease the pulmonary capillary wedge pressure because volume is less, and also decrease the capillary hydrostatic pressure. So all these key features you should be remembered for hypovolemic shock. Guys, talking about the cardiogenic shock. In cardiogenic shock, this will seen in MI, arrhythmia, and in the cardiomyopathies. Primary problem is heart not able to sufficiently pump the blood out from this chambers. So what will be the key feature? There will be the decreased cardiac output, increase systemic vascular resistance, increase central venous pressure. Earlier it was decreased, but in cardiogenic shock, central venous pressure is increased. Pulmonary capillary wedge pressure is also increase, and this increase can lead to the pulmonary hydrostatic pressure increase, leading to pulmonary edema. Very, very important part. Also, there will be the cold, clammy skin, poor response to the fluids, and high filling pressure plus low cardiac output will be there. The next shock is septic shock. That is septic shock, which is a type of a distributive type of shock, and it will seen in the bacterial toxins. Guys, the bacteria when attacks for your body, they always release some chemicals like the cytokines, and these are your nitric oxide. Now, the primary problem is there will be the peripheral vasodilation. Why? Because the nitric oxide is there. Nitric oxide is a vasodilator. So, these vessels will be dilate. Vessels will be dilate. The volume, whatever is present over there, this will decrease and pressure will be decreased. Right? Now, please pay attention that in early septic shock, what is going to be happening in the early septic shock? This is we also called as warm shock, because in this condition cardiac output will be increase, systemic vascular resistance will be decreased because vasodilation, skin is warm, and there is a bounding pulse. But if we'll talk about the late septic shock, this we also call as cold shock, because the cardiac output is now decreased, systemic vascular resistance is increased, and there is hypotension and acidosis. So guys, these two features between the septic shock early and late you should be remember. And also remember guys, this is the only shock where the systemic vascular resistance is decreased and skin is warm initially. Skin is warm initially. Next is anaphylactic shock, which is also a type of distributive shock. This will seen in IgE mediated mast cell degranulation. Mediators are histamine, leukotrienes. And what is the key feature for this anaphylactic shock? Decrease systemic vascular resistance, increase capillary permeability leading to edema, and there will be the bronchospasm and hypotension. And the drug of choice for anaphylactic shock, you already studied in various areas, that is epinephrine, right? Epinephrine, please remember, this is the drug of choice. Then the neurogenic shock, which is also a type of distributive shock. And guys, this is seen due to the spinal cord injuries and during the spinal anesthesia. And primary problem is there is the loss of the sympathetic tone. And if sympathetic part is gone, guys, what will be happening? There will be vasodilation, decrease heart rate. So guys, what is going to be happening? There is the systemic vascular resistance is decreased, bradycardia because loss of sympathetic, so parasympathetic dominance will be there, the vagal dominance will be there, and skin will be dry and warm, and only shock with hypotension plus bradycardia. Very, very important. So the one-liners, for exam point of view, you have to be remember that fastest reflex in shock, that is baroreceptor reflex, auto transfusion, that is in early hypovolemic shock, warm shock, that is septic, which is early and anaphylactic and neurogenic, bradycardic shock, that is neurogenic, and high pulmonary capillary wedge pressure, it is in cardiogenic shock. And the drug of choice in anaphylaxis, that is your anaphylactic shock, that is epinephrine. Very, very important part. I hope all you now can easily remember, and if such question asked in the exam, guys, you can easily answer them, right? Now coming to the next question. The next question is, a patient in the septic shock has warm extremities and bounding pulse, which mechanism best explains the hypotension? Guys, as you can see, that septic shock and the warm extremities and the bounding pulse, this is which type of septic shock? Early or late? This is early, right? This is early. Now guys, please tell me, as we have already discussed about all the type of shock, what is the right answer? What is the right answer of this? This is right answer of this question is the loss of arteriolar tone due to the nitric oxide. So guys, we know in the septic shock, the bacteria release the chemicals like the nitric oxide, and in the nitric oxide, what is going to be happening? The vasodilation is going to be there and leading to hypotension, right guys? Hypotension, right? So there is decreased cardiac contractility, no guys. Reduced blood volume, no. Increased vagal tone, no guys. So this is loss of the arterial tone due to the nitric oxide. Just now we have been covered all of this part, so please pay attention. This is a type of early septic shock. The bacterial cytokines like the TNF alpha, interleukin 1, nitric oxide, and the nitric oxide synthase are increasing. The effect of nitric oxide, there will be widespread arterial vasodilation, right guys? There will be the systemic vascular resistance will be decreased, and mean arterial pressure will also be decreased, lead to the hypotension despite normal or increased cardiac output. So guys, please pay attention. In septic shock, hypotension is due to loss of arteriolar tone, not due to the heart pump condition, right? Please pay attention, very, very important part, because most of the time, most of the student, they gets confusion. Sir, what about this septic shock, cardiogenic shock, neurogenic shock, anaphylactic shock, all of these different type of shock. But in this session guys, I try to bring all of this together so that you can easily understand and you will never get confusion in between all of this shock. Now coming to the next question. A patient with acute myocardial infarct develops hypotension, raised JVP, pulmonary edema, which is the most likely shock. Guys, you can easily understand if this is the heart, guys, MI is mostly happens to which area? MI is mostly happens for this area. And guys, if this area is failed to pump the blood out from this area, there will be a traffic jam over here leading to increased PCWP, and what going to be happening? This will lead to the edema in pulmonary area, and also there will be a jam into the right side, so JVP will be also increased. And guys, which type of shock this is? This is answer of this question is this is your cardiogenic type of shock, right? So just now we discuss about different type of shock. Coming to the next question. Now you have to be answer, because just now we discuss in a detailed manner all about these questions. Now let's practice. A sudden severe hypotension with bradycardia following inferior wall MI is due to the activation of. Yes guys, you have to be answer. Severe hypotension with bradycardia following the MI, right? We are talking about the left side of the heart condition. It is for which reflex? This is for Bajol-Jaris reflex, right? Bajol-Jaris reflex. So earlier we discussed about all the reflexes. Coming to the next. Now, few things you should also remember about the Cushing reflex. What is the Cushing reflex? Because most of the time they used to ask about this Cushing reflex. So guys, please pay attention. It is a physiological response to raised intracranial pressure, and this aim to maintaining the cerebral perfusion. So whenever the brain intracranial pressure will be increased, what will be happening guys? This higher pressure will compress all the vessels into the brain, and there will be the decreased perfusion for the or decreased blood circulation inside of the brain. Although in all the areas everything is fine, BP is fine, volume is fine, the blood circulation is fine, but inside of the brain, due to the high intracranial pressure, all the pipeline they get compressed, and due to this compression the brain is getting less blood supply. As we know, the brain is the very important part of the body. It required continuously the adequate blood supply. So guys, what brain will do? Brain is having all the power to regulate all the organs inside the body. So what will be happening? There will be the triad will be there, and in this triad what will be happening guys? First of all, this is there will be the hypertension, there will be the bradycardia, there will be the bradycardia, and there will be the irregular respiration. So there will be hypertension, bradycardia, and irregular respiration you can see in the Cushing reflex. So once again, whenever the high intracranial pressure is there, body try to increase the cerebral perfusion, which called as a Cushing reflex. The three things you have seen in this condition: hypertension, bradycardia, irregular respiration. Hypertension, why? Due to increase the systolic BP, and there will be the widened pulse pressure. The mechanism is just now we discussed over here. The high intracranial pressure will decrease the cerebral perfusion pressure, and this cerebral perfusion pressure is equal to mean arterial pressure minus intracranial pressure. So there will be the medullary ischemia and sympathetic activation will be there. Strong sympathetic activation lead to what? The increased systemic vascular resistance, increase the BP to restore the cerebral perfusion pressure. But whenever BP will be increased, what will be happening, guys? The baroreceptor will be fire, and these baroreceptor will decrease the heart rate, bradycardia. So guys, this is how the BP will be high, but there is a bradycardia and there is the brainstem compression which lead to the irregular breathing. So this is the mechanism of the Cushing reflex. The clinical significance, it indicates dangerously raised intracranial pressure. Immediately you have to treat, you have to see this patient, and this seen in the head injury, intracranial hemorrhage, brain tumor, and hydrocephalus condition, right? Coming to the next, which murmur increased during the inspiration? Option A, mitral regurgitation, aortic stenosis, tricuspid regurgitation, and the mitral stenosis. The right answer of this question is the tricuspid regurgitation. Option number C, that is tricuspid regurgitation. Guys, please pay attention. The few things you should know about the murmur. First of all, what is the murmur? Any abnormal sound apart from the four sound of the heart, any abnormal sound of the heart we call as a murmur, and in the simple form we can remember like these are the खरकर. तो ये जो मोटर है बेटा, इसमें अगर अलग से कोई सी भी आवाज आने लगे तो उसको क्या बोलते हैं? खरकर, and in the medical term we can use them as a murmur, right? Now please pay attention. There is something called as Carvallo sign. What is the Carvallo sign? The Carvallo sign tells that the right-sided cardiac murmurs, this always increase during the inspiration. This is your Carvallo sign. Guys, in the inspiration, what happens? Our thoracic area expands. If the thoracic area expands, guys, the intrathoracic pressure will be decrease. Intrathoracic pressure will be decrease, right? Now, this will lead to what? This will try to suck the blood from the veins. So venous return will be increased to the right side of the heart. And this leading to what? The right ventricular filling will be increased. So this area expanding, creating the negative pressure. Pressure is decreasing. So it will try to suck the blood from the veins. And guys, this lead to right atrial filling increase, leading to right ventricular filling will be increased. Guys, during this condition, if there is a tricuspid regurgitation, means this tricuspid valve is not properly closed, guys, what will be happening? This will lead to increase the regurgitant flow across the tricuspid valve. So this blood will start moving upside more and more, leading to what? Leading to the more prominent murmur. This murmur of the tricuspid regurgitation becomes louder. So the two things you should remember, that inspiration, it will always increase the right-sided murmur, but expiration is always increase the left-sided murmur. So guys, these keywords you have to be remember for your exam point of view, that all the time if the examiner is mentioning in the MCQ that inspiration murmur they are talking about, you always have to think about the right side of the heart. But if the examiner is asking about that expiration murmur, guys, you always have to think about the left-sided murmurs. Also please remember, the murmur is the prolonged sound caused by the turbulent blood flow, right, which across the cardiac valves. So there are the different type of murmurs, like the systolic murmur. Guys, the systolic murmur means when the heart is going into the systole, means heart is contracting. During this time, if any of the sound is coming up, we call it a systolic murmur, which we can divide into the different part. That is number one, ejection systolic murmur, which is also called as crescendo decrescendo murmur, which is also called as diamond shape murmur. Diamond shape murmur. This will causes due to the flow across narrowed semilunar wall. So guys, if this is your heart and here is your semilunar wall. So guys, what will be happen if semilunar wall is not opening properly? It becomes narrow. This will causes the systolic murmur. It is seen in aortic stenosis and in pulmonary stenosis. The another one systolic murmur, that is your hollow systolic or the pan systolic murmur, which is seen in that different condition, and it is due to the regurgitation or the septal defect. So this is your heart. So guys, what could be happen when these areas are going to be contract? Blood can move from this area to this area to this area, or there could be a defect in the septum of the ventricle. So these three conditions can show you the holosystolic murmur. So you can see this could be seen in mitral regurgitation, tricuspid regurgitation, and the VSD, that is your ventricular septal defect. As we just now discussed, the tricuspid regurgitation murmur, they increase or becomes louder during the inspiration. We call it as a Carvalho's sign, right guys? Carvalho's sign. And the late systolic, this could be seen in the mitral wall prolapse, which is a type of click, and the late systolic murmur. Talking about the diastolic murmur, which is always pathological. Guys, please remember, always word we used very rarely in the medical part. We used to say all the time maybe or may not be, but once we could say that this is always or never, guys, you should be always have to be more focused over here. So please pay attention. The early diastolic murmur, this will due to the semilunar wall regurgitation, and this could be seen in AR, aortic regurgitation, and in PR, pulmonary regurgitation. Similarly, the mid-diastolic murmur, this is due to the AV wall stenosis, and it could be seen in mitral stenosis, tricuspid stenosis, right? Tricuspid stenosis, this can be increased or become louder with the inspiration, right? Now the next is late diastolic or the pre-systolic murmur, which could be seen in the mitral stenosis. And the last one, that is your continuous murmur. This continuous murmur here in the both phases, during the systole, during the diastole, and guys, this could be seen in the PDA, patent ductus arteriosus, and in the AV fistula. This is we also called as machinery murmur, right guys? Machinery murmur. So I hope now if the murmur question can come, you can easily answer them, right? Now, coming to the next question, the isovolumetric contraction occurs between. Guys, please, you have to be understand first of all that cardiac cycle, very prominent part. Most of the time the examiner favorite, they used to ask from this area the questions in the different language. So what is the right answer of this question? Isovolumetric contraction occurs between. Yes, the right answer of this question is AV valve closure and the semilunar opening. The AV valve closure and the semilunar opening. As the word is telling, iso means same, volumetric means volume, and contraction means during systole. So what is the area when the volume is same and this time the ventricle is in systole? So ventricle is in systole. This is we called as isovolumetric contraction, right? Isovolumetric contraction. So guys, please pay attention that isovolumetric contraction, this is phase of the early ventricular systole. So first, most of you gets confusion between the isovolumetric contraction and relaxation. Please focus over here. If suppose this is your heart, guys, we know that this is your tricuspid valve, this is your bicuspid valve, which is also called as mitral valve, or also called as bicuspid valve. This is we called as tricuspid valve. Now combinedly, collectively, both these valves are present between the arteria, that is between the atria and the ventricle. So combinedly we can also call them AV valves. Now similarly, the two more walls is present. One is over here and one is over here. Guys, this is we called as aortic wall, and this is we called as pulmonary wall. Guys, these walls are actually made up of like a half moon shape. And guys, due to this condition half moon shape, combinedly we can call them semi-lunar wall. What we call this? Semi-lunar wall. So this is the semi-lunar wall, this is the semi-lunar wall. This is we call as pulmonary semi-lunar wall, and this is we call as aortic semi-lunar wall. Guys, please one thing also remember. Whenever the heart sound comes, this heart sound comes due to the wall closure. Wall opening never creates sound. Only the wall closing can create the sound. Like in the same way, when you are opening the door, तब आप दरवाजा खोलते हैं, guys कोई भी sound नहीं आता है. But once you close the door, guys it creates the sound. दरवाजा बंद करने पे वो जोर से जाके टकराता है and it creates the sound. So guys, similarly inside the heart, whenever these valve will be closed, it creates the S1 sound, and whenever these valve will be closed, it creates the S2 sound. So S1 due to the AV closure and S2 due to the SLV closure, right guys? SLV closure. So I hope now you can easily understand. Now please pay attention. Whenever these valve is closed and these valve is closed, and during this time, if ventricle is contracting, guys, what do you think? Can any volume can go out from this area? No. So guys, if ventricle is contracting against the both wall is closed, guys, volume can remain same, and this phase we called as isovolumetric contraction phase. Similarly, during this time, when these walls are closed, and if these ventricles are relaxing now, guys, in this condition again you can see that both walls, upside and downside wall is closed and ventricle is relaxing. Guys, no volume can enter into the ventricle, so volume can remain same, and this phase we called as isovolumetric relaxation phase. So this is how whenever the volume remains same for the ventricle, we used to say isovolumetric, and if this is during the contraction, isovolumetric contraction, this is during the relaxation, isovolumetric relaxation, right? Now, so this is the phase of early ventricular systole. Ventricular muscle contracts, all valves are closed. Very, very important. This is the important part. Valves are closed. Ventricular pressure rises rapidly, but no changes in the volume. It starts with AV valve closure. This is mitral and tricuspid, and it produces with sound, guys. Just now we discussed S1, and it ends when the ventricular pressure exceeds aortic and pulmonary pressure, and then the semilunar valve will be open. So guys, isovolumetric contraction, it is correspond with the S1 sound, and isovolumetric relaxation correspond to the S2 heart sound, right? I hope now you can remember. Coming to the next question, which change shifts the PV loop rightwards? What is the PV loop? That is pressure volume loop. And guys, this pressure volume loop we always talks about for the left ventricle, right? So this left ventricle pressure volume curve, if you will see, this will look something like this. Guys, in this curve, if you will see, on the x-axis, this is talking about the volume, right guys? This is talking about the volume, and on y-axis we are talking about the pressure. Guys, we first should know what is the volume of the left ventricle. So guys, the left ventricle, when it's completely filled up, how much amount of the blood can come up, we called as end diastolic volume, and this is 120 ml. Then when this ventricle is contracting, how much amount of the blood will be eject out, this we called as stroke volume, and this is around 70 ml. So comes 120 but exits only 70 ml. So guys, how much is remain? The remaining blood we called as end systolic volume, and this is 50 ml. If you will define in the percentage, guys, out of this 120, the 70% is ejecting out, and this ejecting from the left ventricle. So we use the word fraction whenever we are presenting anything in percentage. So जब भी अपने को कोई भी percentage में दिखाना है, we always use the word in the fraction. So guys, this fraction for the left ventricle, blood is ejecting, so we called as left ventricular ejection fraction, and this should be the 60%. This is the normal pumping. If the left ventricular ejection fraction decrease less than 40%, guys, this will suggestive of inadequate pumping of the heart, and we called as heart failure, right? This condition we called as heart failure. So guys, now we understood that what is the volume which can be present at a time inside of the left ventricle, how much volume can be ejected out, how much volume can remain. So guys, please pay attention. This EDV is also called as preload. This EDV is also called as preload, means that is the load which is putting on the left ventricle to pump the blood out. Guys, please pay attention. Once again comes to this question, the which chain shifts the PV loop towards the right side. So guys, this is the right side, this is the left side. Guys, the right side is happens whenever the EDV is increased, and left side happen whenever EDV is decreased. So guys, you can see over here what is the right question. The right answer of this question is option number C, that is increase the preload, right? Increase the preload. So EDV is primarily determined by the preload, but systemic vascular resistance, SVR, systemic vascular resistance, the vessel are resisting like this. This is we called as afterload, which is putting after the heart. So these vessels putting the load on the heart we call as afterload. Guys, increased preload, it happens when the venous return will be increased, increased ventricular filling will be happening, and EDV will be increased, right? EDV will be increased. The pressure volume shifts towards the right side. So guys, please pay attention. Stroke volume is increased via the Frank-Starling law, guys. We studied in the classes with the rubber band method, right? Rubber band, Frank-Starling law. Now please pay attention. What is the changes with the condition and in the pressure volume loop effect? So guys, whenever the preload will be increased, there will be the rightward shifting. If the preload decrease, the curve will shift towards the left side. Whenever the contractility will be increased, the curve will shift towards the left and it will become taller. But whenever the afterload will be increased, the curve will be taller, but it will become narrower, right? It will become narrower. And if we'll talk about this curve, guys, please pay attention on the point number A. This is suppose A, B, C, D. Guys, in this A, there will be the mitral valve opening. At this point, mitral valve open, and here mitral valve close. Point number C, aortic valve open, and at point number D, aortic valve close. This phase we called as isovolumetric contraction phase. This is we called as isovolumetric relaxation phase, and the difference of this we called as a stroke volume. So this is the different areas which could be asked in the pressure volume curve. They can give you that arrow mark over here like this, or over here that what is the happening at the different areas, right? So this is about the pressure volume loop curve. Coming to the next, the prolonged PR interval with all P waves conducted suggests, guys, PR interval prolongation. Multiple times we studied in the class that this is telling us about the heart block, and which type of heart block. So we know if the P wave is happening and PR is constantly prolonged, no drop beat, this is your first degree heart block. So this is your first degree heart block. Guys, please pay attention. What is the first degree AV block? Guys, this first degree AV block means the PR interval is prolonged. And how much prolonged? It should be more than 0.20 second. There should be every P wave followed by the QRS, no drop beat should be there, and there should be a delayed AV conduction, right? Delayed AV conduction. It's seen in the increased vagal tone, beta blockers, digoxin, and in the inferior wall MI. Then the sinoatrial block. The sinoatrial block, the problem at the SA node. It causes missing P wave. Earlier P wave was present but no drop beat. Now no drop beat but P wave is absent, and PR interval of conducted beats normal. that is normal. Now the complete heart block, this is we also called as third degree heart block, third degree heart block, or also called as complete atrioventricular dissociation, complete atrioventricular dissociation. So this complete heart block, there is a no relationship between P waves and the QRS. Guys, this is happens when the atria and ventricles become separate completely. They works independently. Our PR interval is variable. It is could be happen like this, that ideally P wave should come, then the QRS, P wave, QRS, P wave, QRS. But what happens over here? The P can come at any area, QRS can come at any area. Guys, in the class we studied with the story of the Bhabijis, so all of you now can remember what is the different type of heart block. Now please pay attention. The condition in the first degree AV block, the PR interval will be prolonged, PRA will be prolonged, and PQRS relation will be all conducted, all fine. In Mobis type 1, Mobis type 2, this is your second degree heart block. Guys, in Mobis type 1, the PR interval will be gradually prolonged, right? Gradually prolonged, and there will be the drop beat, means QRS will be absent. In Mobis type 2, the PR will be normal and constant, but there is the drop beat, means no QRS. And in complete block, the PR will be variable, complete AV dissociation will be there. And in SA block, PR will be normal, but there will be the missing P waves, right? Missing P waves. So this is how you can differentiate between all these heart block areas. Coming to the next question, that phase 2 of the ventricular action potential is due to sodium influx, calcium influx, potassium influx, or the chloride influx. So where is the phase 2? This is your phase 2. Guys, the right answer of this question, many of you has already answered. This is your calcium influx. Guys, if we talk about this curve, we studied that in phase 0, there is sodium influx, which we called as depolarization. In phase 1, potassium efflux, which is we called as early repolarization. But to maintain the positivity inside the cell at this area, which we called as the plateau phase, guys, what will be happening? There will be calcium influx and potassium efflux will be there. So what will be happening? One positive is coming into the cell, one positive is getting out from the cell. So guys, no positivity will be lost. The curve will shift towards the straight line, become the plateau phase, right? This is we call as phase 2. And in phase 3, this is only due to the potassium efflux, and this is we called as late repolarization, and this is we called as polarized state, right? Polarized state. So guys, this curve is very important. Now you can easily see that what is happening in the phase 2. In phase 2, there will be the calcium influx, right? So please remember about during phase 2 that L-type calcium channels will be open, calcium influx into the cardiac myocyte, inward calcium lead to balance with the outward potassium efflux. It triggers the calcium and induced induced calcium release phenomena, which is seen in the cardiac muscles, right, from the sarcoplasmic reticulum. It is responsible for the cardiac muscle contraction. It prevents the tetany via prolonging the refractory period, right? Refractory period. So phase 2 of the ventricular action potential is also called the plateau phase. So just now we discussed what will be happening in the phase 0, 1, 2, 3, 4. So all of these conditions is mentioned over here. Coming to the next, that Kussmaul sign is typically seen in. Very important, guys. The Kussmaul sign is typically seen in. The right answer of this question, Kussmaul sign is typically seen in, this is in constructive pericarditis, right? Constructive pericarditis. Now guys, please pay attention. What is the Kussmaul sign? The Kussmaul sign means during the inspiration, whenever we are doing the inspiration, the thoracic chamber is increase in the size, so pressure decrease and all the blood pull into the heart. So what will be the central venous pressure or the jugular venous pressure? The jugular venous pressure will be decrease. So during the inspiration, JVP is always decrease. But suppose during the inspiration, JVP is remain increase. This is abnormal condition. We called as a Kussmaul sign, right? Kussmaul sign. Very, very important. Guys, don't be confused with the Kussmaul breathing. Kussmaul breathing, which seen in the DKA, which is hyperpnea and the tachypnea, fast and the deep breathing, like this. That is Kussmaul breathing. This is Kussmaul sign. What is the Kussmaul sign? Whenever during the inspiration, the JVP remains high, we call it as a Kussmaul sign, which could be seen in the constructive pericarditis or any right side heart anomaly, right? So in constructive pericarditis, what is happening? This is the rigid, non-compliant pericardium is there. That is hard pericardium is there, which is not allowing to move the heart or to extend the heart. Now, this will increase the venous return. What is going to be happening? When the venous return will be increased, it block backs up in the veins. So guys, what is going to be happening? This heart is not able to dilate, so no blood can easily pump into the heart. So guys, this blood remain into the veins, right? This remains into the veins. Now please pay attention. This JVP rises during the inspiration, we call it as Kussmaul sign, and this is classically shows impaired right ventricular filling. Now guys, please pay attention. Now please attention that this is cardiac tamponade. The next condition is cardiac tamponade. In cardiac tamponade, the pericardial fluid restrict the heart, right? Means if suppose this is your heart, and if outside of the heart we know there is a pericardium. Guys, if this is some blood is come into this area, outside area of the heart, this is we called as cardiac tamponade. Guys, what will be happening? This pericardial effusion will not allow to expand the heart. Guys, if heart will not expand up, what will be happening? The blood cannot come properly into the heart. So the cardiac output will be decreased. So BP will be decreased. If not all blood able to come or fall down into the heart, guys, what will be the neck veins? These neck veins will be dilated because there is the traffic jam. So this is another feature you can see. And if suppose from the outside using of the stethoscope, if you want to listen the sound, guys, the sound coming due to this valve closure, and there is the presence of the fluid in between this, guys, you cannot hear the proper heart sound. Again, this is we called as muffled heart sound, right? So this is the condition which can be seen in the cardiac tamponade. So JVP remain elevated, and this tamponade shows the pulsus paradoxus. Guys, Kussmaul sign can be seen in the cardiac tamponade, but it is not significant for the cardiac tamponade. Please remember this part. This three features, which three features? That is number one, dilated neck veins, number two, muffled heart sound, and number three, this is the hypotension. Guys, these three things combinedly collectively we called as a Bake's triad, which is seen in the cardiac tamponade. Very important, repeatedly asked MCQ. Guys, in the left ventricular failure, what will be happen? This affects the left ventricular function. This is not any direct relation to the right sided filling with the respiration, and JVP may be normal, mildly can be raised, but no paradoxical rise will be there. So I hope now you can easily remember between this constructive pericarditis, cardiac tamponade, and left ventricular failure. So guys, many of you now thinking, sir, why the venous return increase? Guys, no, venous return will be venous return is there, but this venous return cannot be dropped into the right atria. So this venous return is leading to what? Increasing the pressure into the central veins, JVP. So this is how there will be the increase the JVP during the inspiration, right? So this is what actually is mentioning. So venous return is decrease in the constructive pericarditis condition. So guys, now please all the time remember between this constructive pericarditis, cardiac tamponade, and the left ventricular failure. So now the last quote to all of you, that's if you can change your mind, you can change your life. because guys, all the things in our life is depend only about the thinking. If we'll think positively, the things will be happen with us all the time positively. But if you will remain negative, guys, all the time, that's negative thoughts will ruin our life. So guys, stay positive, stay calm, and all the time give your 100%. This is all from my side from this cardiovascular system. I hope you liked it and you loved this session. Thank you, thank you, thank you very much.